So today is the grand rounds for April 13th, and the activity code is listed there for you. I'm going to go over some instructions in the next slide, just in case. But if you are interested in claiming CME credit for viewing this presentation, you'll want to make sure that you do the process we're going to talk about here. Make sure you do that before midnight tonight, and the activity code is listed there. But if we go to the next slide, so here you'll see the activity code again, but if you have not yet registered, you'll need to text your email address to the toll-free number listed there. Once you've done that, you can then text the activity code for today, which is listed there, but you'll need to text attend and then the activity code. If you have any issues with this, please feel free. I know most of you have already done this. So if you have any questions, please feel free to reach out to me and I'm happy to help. Next slide. So as we get started here, we just want to take a moment to remind everybody, if you have not yet already, please make sure that you do mute your microphone. We also ask that you please remain attentive and engaged in the session. I do know that if you have questions, please feel free to put those in the chat box, and we will be taking a look at those as we go through. And also, I will be putting in the chat box the link to provide feedback for our presenter today. So please be on the lookout for that as well. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and our department's mission statement is listed there for you. Next slide. CME transcripts. So if you do claim CME credit for viewing our presentations, you may want to check every so often to make sure that you are receiving those credits. Again, you have to request those before midnight on the date of the presentation, or if you do them asynchronously, you'll just want to make sure that you do log in to verify that your transcript is correct. But if you have any issues, you're welcome to reach out to the CME office, or you can also reach out to myself. Next slide. Also, along with that being said, you'll need the transcript if you are looking to gain AAFP credit. Those who are members can do so, but you'll need that CME transcript as well for that. So their information is listed for the AAFP, but please feel free to reach out to me as well if you have any questions. Next slide. We also want to make sure that we do mention that our FCM Grand Rounds presentations, it is our goal to address these nationally established physician core competencies, which you can see listed there. Next slide. And we also need to mention that Dr. Kour has no financial relationships with ineligible companies to disclose. Next slide. So she is going to be presenting to us today for the topic Systemic Lupus Erythematosus. I did not probably say that right. Clinical manifestations and diagnostic evaluation. So I'll let her give a better, she can pronounce it better than me. I'll let her go ahead and get started with her presentation.
Hello, everybody. My name is Maya Kour. I'm one of the UT physicians. I'm a rheumatologist, but I'm also a primary care physician. I see patients downtown at the RBG campus. I see rheumatology patients, and I also work as a primary care physician with the general medicine residents on the 3rd floor. Thank you for letting me speak in the grand rounds today. And we're going to talk about systemic lupus erythematosus, or SLE. It's going to be some, review on that topic, and hopefully we'll get your questions towards the end, and hopefully this will add something at the end of the presentation. So our objectives for the lecture today is mainly to understand different clinical manifestations of systemic lupus erythematosus, which I'm referred to as SLE throughout the presentation, recognize the importance of serologic testing and evaluation of SLE, and then to go over some of the differential diagnosis of a positive ANA, which might go beyond systemic lupus erythematosus. A little bit of history. The word lupus, it's Latin for wolf, is attributed to the 13th century physician Rogerius, who used it to describe erosive facial lesions that were reminiscent of wolf's bite. Then Sir William Osler and Morris Kapusi recognized that lupus is a systemic disease, and so the name came as systemic lupus erythematosus. But it seems like initially it was mainly described as a skin disease until they further noted it as a multisystemic disease. SLE is a chronic autoimmune disease of unknown cause that affect virtually any organ of the body. Immunologic abnormalities, especially the production of ANA antibodies, are a prominent feature of the disease. And the interesting thing about it is patients can present from very mild symptoms when they have just mild joint disease or mild skin involvement to really life-threatening renal, hematologic, or central nervous system involvement. And the clinical heterogeneity of the lupus and the lack of the pathognomonic features or certain specific diagnostic testing makes it a challenging diagnosis to make for the clinicians. And to complicate matters more, patients can present with one of the clinical features of lupus, which can resemble other autoimmune diseases or infections or hematologic diseases. So trying to figure out if this is part of another disease or is this symptom the patient's presenting with is part of lupus symptoms. The reported prevalence of lupus in the United States is about 20 to 150 cases per 100,000. And the increased frequency of lupus among women has been attributed in part to the estrogen hormonal effect. And we partly understand that because we notice that lupus tends to be more active and flares up during pregnancy. And so we think that the estrogen has to do with that. And thus, it being more common in females than it is in males. In the United States, the prevalence of lupus is higher among Asian, African American, African Caribbean, and Hispanic American individuals compared with white individuals. And African American, Mexican, Hispanic individuals in the United States tend to have a poorer renal prognosis than white individuals, a finding that's not entirely independent of socioeconomic status. As far as the etiology for lupus, and as we mentioned in the previous slides, that we don't really know the exact etiologies. There are multiple, suggested risk factors or factors that play into why this patient has lupus and the other doesn't. And that's a very common question. When we actually diagnose patients in clinic with lupus, the first thing the patient asks is like, okay, what did I do wrong? What can I do? What do you think is the cause of this? Are my kids are going to have the disease? So unfortunately, we don't have clear answers to all these questions. In general, as we know, with a lot of medical conditions, genetic factors play a role, and we always ask about family history whenever patients are presenting to, the clinic with, in general, any medical conditions. So of course, having a positive family history for lupus or any other rheumatologic or autoimmune conditions will increase the chances of the patient having the disease. Hormonal factors plays a role, and it being more common in females, it being also flaring up during pregnancy. Environmental factors, as we know, it's one of the suggested etiologies for a lot of autoimmune diseases. Certain viruses like Epstein-Barr virus can stimulate antigen-specific cells in the immune network and provoke, an autoimmune disease. UV light can stimulate keratinocytes to secrete different interleukins 1, 3, 6, and TNF alpha, and they tend to stimulate the B cells to make more antibodies. So that is a fact that we know for sure, and that's one of the recommendations for our lupus patients is try to avoid sun exposure and be very careful with UV light exposure, since we know that this can provoke a flare. So one advice we give those patients is to try to always stay in the shade, wear sunscreen, long sleeves. That's one thing they can do to help improve their disease or prevent further flare-ups. And then a couple of other suggested etiologies like silica dust found in cleaning products, soil, pottery materials, cement, and cigarette smoke to be factors that can increase the risk of developing lupus. Also, any present or past history of cigarette smoking, which we know is an etiology for a lot of problems and medical conditions, including cancer. So do we really know, at this point, what is causing lupus? Not really, but we do have several, factors that could play in and increase the chances of one patient having it more than the other. But a commonly asked question in clinic, what caused it? And the answer to that is, we don't know yet. And in this image, as we notice, systemic lupus erythematosus or lupus, in general, can affect any organ system going from head to toe. Certain organ systems tend to be more involved than others. But in general, cutaneous and mucosal complications can be seen in about 70% of the patients, neurologic complications in about 50% of the patients. Chest pain caused by either pleural effusion or pericarditis, pericardial effusion can also be seen in about 20 to 40% of the patients. Renal complications here listed 30%. I do feel like I see much more renal complications related to lupus in my clinic. GI complications in about 50% of the patients, hematologic complications, and of course, arthritis and musculoskeletal complications being as common as 85%. We see Raynaud sometimes in association with lupus in some of the patients. So any organ system can be involved, and the severity can range in each organ system from mild to very severe or life-threatening. And again, that's what makes lupus a more challenging diagnosis for the clinicians in general. So I'm going to go over some of the clinical manifestations of lupus and kind of talk about each of them in a little bit more detail. And I wanted to touch on the constitutional symptoms that the patients can present with, and it can be one of the earliest symptoms of lupus. Patients come in with fatigue. So fatigue is very common, and it occurs in about 80 to 100% of patients. And its presence is not entirely correlating with disease activity. So they could still have fatigue even though their lupus isn't actively active at this point, or they're not in a flare-up. But because if lupus is very commonly associated with depression or sleep disturbances or fibromyalgia, which could explain a lot of the fatigue symptoms lupus patients can come with. Fever can also be a manifestation of early disease and active disease, and can be seen in about 50% of the patients with lupus. Myalgia is common in lupus, whereas severe muscle weakness, talking here about myositis and muscle inflammation, is not as common, but if it's present, it can, pose even a more challenging diagnosis to make, as this patient have active lupus and myositis, kind of having what we call an overlap syndrome. But more commonly, patients will come complaining of myalgias and muscle pain, but not necessarily myositis, or myositis would be less common cause for that. As far as weight changes, they are also very commonly seen in patients with lupus, and they can be related either to the disease itself or to the treatments that we are using to control the disease. Initially, we noticed that a lot of patients will have weight loss, and that could be unintentional weight loss related to active inflammatory process. Patients have a new disease that we haven't diagnosed yet. They have these kind of fevers, fatigues, decreased appetite. Or it could be a side effect of the medications that we're trying to use to control the disease. And hydroxychloroquine, surprisingly, is one of those medicines. It's a very common medicine to be used in lupus. It's the backbone of lupus treatment. But I recently had a couple of patients in clinic who I tried to challenge them to tolerate a very low dose of hydroxychloroquine, and they just couldn't. They said they had to take vomiting, nausea, vomiting medicines to be able to tolerate the hydroxychloroquine. So it could be, medication induced, or some GI disease, either related to the disease itself again, or to the medications that were given to the patients. For example, peptic ulcer disease caused by high dose steroids that we sometimes tend to use in those patients to control their acute flare-ups. Now, weight gain in lupus can also be seen, and that could be either because of salt and water retention related to, for example, having lupus nephritis, nephrotic range proteinuria, or because of increased appetite related to our famous medication in lupus, glucocorticoids. So glucocorticoids could cause, of course, increased appetite and weight gain. So, the weight change can be different in different patients. So initially, we'd expect more of an unintentional weight loss, or some anorexia related to medication side effects. And then later on, we could see patients end up getting weight gain, either due to nephrotic syndrome, lupus nephritis, or because of medications we use, commonly steroids. As far as the musculoskeletal symptoms, which are very, very common, I would say 90% or even 100% of lupus patients will complain of either arthralgias or arthritis. And that also can be one of the earliest manifestations of the disease and can sometimes be the trigger for checking an ANA. In general, arthritis that usually is seen in lupus is usually migratory, polyarticular, and symmetrical in about 70% of the patients. So the way we're describing this arthritis is kind of overlapping with how we describe arthritis in rheumatoid arthritis: migratory, polyarticular, and symmetrical, and usually it tends to involve smaller joints. It can be, of course, painful. The key here is to make sure that we understand that lupus arthritis usually is non-erosive, so we do not expect to see erosions on x-rays. It rarely causes deformities as well. If we see erosions, deformities, we should think, does the patient have rheumatoid arthritis rather than lupus? And this is a table that kind of briefly touches on, some changes or differences between what we expect to see in lupus and rheumatoid arthritis. And we notice here synovial hypertrophy is rarely seen in lupus, whereas commonly seen in patients with rheumatoid arthritis. The other thing is subcutaneous nodules. We rarely see subcutaneous nodules where elbows tend to be a common site in lupus, whereas it can be seen in about 30 or 35% of rheumatoid arthritis patients, especially if they have a positive rheumatoid factor. Erosions are very rarely seen in lupus, but we could commonly see erosions in patients who have arthritis due to underlying rheumatoid arthritis. Again, rheumatoid factor increases the chances of having erosive arthritis. And deformities, which tend to be, again, more common in rheumatoid arthritis and less commonly seen in systemic lupus erythematosus. So this is a picture that shows arthritis that we do not see in lupus. So this isn't what we expect as far as physical exam of the joints of the hands or looking at the x-rays of the hands. This is not what we would expect to see in patients presenting with arthritis due to underlying lupus, where this kind of is more consistent with what we would expect to see in patients with rheumatoid arthritis. So when we see this kind of picture, we should try to think of an alternative diagnosis rather than lupus. Although there is a disease that we call lupus when there is an overlap between rheumatoid arthritis and lupus, and in that case, we tend to see erosive arthritis along with lupus, but it's not common. Moving on with mucocutaneous involvement as far as clinical manifestations of lupus, most patients develop skin and mucous membrane lesions at some point throughout their course of the disease. And the most common lesion is what derive the name of the disease, those facial eruptions that characterizes acute cutaneous lupus erythema or the butterfly rash. And usually it presents as erythema in the malar distribution over the cheeks and the nose. And the key point here is that it is sparing the nasolabial folds and typically appears after sun exposure and can, persist for a long time after sun exposure. So it's not like the flush that patients get or people get just because of being outside in hot weather, and then it goes away directly as soon as they go into a cooler place. Some patients can develop discoid lesions, and unfortunately, those tend to be more inflammatory and they can have the tendency to scar. And this is a picture that shows a typical butterfly rash that we see in patients of lupus. And a lot of our patients who I see in clinic sent or referred to dermatology for a positive ANA, they would have already researched the malar rash and the butterfly rash, and they will come and tell me, this is what I have. This is the rash, that typically comes up after, I go out in the sun, and it persists for hours after sun exposure. And the key here we notice that it is sparing the nasolabial fold. Some of this malar rash that patients will present with aren't, as clear as those pictures are. And so sometimes it can be challenging to make that diagnosis in clinic, and we may end up asking help from either dermatology or if actually skin clinic from family medicine. They do help us a lot, co-manage a lot of our lupus patients, especially when they have discoid lupus lesions. And here, this is another image that shows the erythematous plaque with scale and pigmentation in the ear causing scarring as part of discoid lupus. And on the right side, we also see another plaque and this patient with discoid lupus. Photosensitivity is common, this is very common in patients with lupus. And as we mentioned before, when we were going over the different etiologies for lupus, we were talking about the importance of avoiding sun exposure if possible. Now, patients do need to have a life, so it's really hard to completely prevent them from being out in the sun, but at least to make sure they're aware of being in the shade, trying to cover up, as I mentioned earlier, making sure they have a good sunscreen on, especially the sun exposed areas, because photosensitivity is most commonly seen on the face, neck, upper chest, and of course the hands, because usually they have direct exposure to the sun. So that's another, thing that patients can present with, and it could be on the review system for patients with lupus. Going over some of the mucocutaneous manifestations, oral ulcers, oral and nasal ulcers are very important and very common manifestations seen in patients with lupus. And it's important to recognize that those are usually painless, as opposed to different kinds of oral ulcers that patients can have, like ophthostomatitis. Usually they are painless, but they can cause some discomfort. So patients may feel them with their tongue or when they're eating, and they may tell you, I do feel something. It's not necessarily painful, but it is causing some discomfort, especially with eating. Some of the nasal ulcers can also lead to nasal septal perforation. So that's something to think of if we have patients presenting with this clinical manifestation. And non-scarring alopecia also, it has been observed in patients with lupus throughout the course of the disease, whereas scarring alopecia is definitely harder to treat and can occur in patients with discoid lupus. And again, here we definitely do ask the help of dermatology and skin clinic so they can co-manage those patients with rheumatology. And these are pictures that just show the oral ulcers that typically are seen in patients with lupus. Again, a very common site for those to happen is the palate, but they can occur in different other places, and that, they are usually painless. Regarding the cardiac manifestations of lupus, they are common, and they could involve any part of the heart, going from the pericardium, myocardium, the valves, the conduction system, or the coronary artery. Pericarditis, with or without an effusion, is considered to be one of the most common cardiac manifestations of lupus, and it occurs in about 25% of patients at some point throughout their disease process. Verrucous or Liebman-Sachs endocarditis is usually a clinically silent disease, and it can produce valvular insufficiency and unfortunately can serve as a source of emboli. So that's another cardiac manifestation. Again, not very common, but it can be seen in some patients with lupus. Myocarditis is not common in lupus, but if it happens, it tends to be severe. And in general, it's important to note that our lupus patients are at increased risk for coronary artery disease. And part of this, it could be the chronic inflammatory process because of the lupus itself, or the medications that we commonly use in lupus, especially in patients who have raging lupus. It's been hard to treat, required higher doses of steroids for prolonged periods of time. That definitely can cause accelerated atherosclerosis. And that's why some of our lupus patients, when they present for example, preoperative evaluations, even though they're in the younger age groups, we don't expect those as compared to general population to need additional cardiac workup prior to certain procedures. But we have to think about these patients as being a little bit higher risk than the other general population when it comes down to that, because of their chronic disease process, because of the medicines that they have used over the years, especially. Raynaud's, again, as we mentioned earlier, it can be seen in lupus, and it is that vasospastic process induced by cold, can be seen in about 50% of patients with lupus, and characterized by intermittent acral pallor, followed by cyanosis and erythroderma. And, a very typical picture of, Raynaud's that you could see in patients. I usually, when I do the review system on my patients who are either referred for a positive NA, trying to figure out if this is lupus, or patients who have chronic lupus, usually part of my review system would be a question about Raynaud's. Do you have Raynaud's? But then, not all patients know what Raynaud's is. So a lot of times I try to ask open-ended questions about, okay, so have you noticed any changes in your skin color? Typically tips of the fingers when you handle cold stuff out of the fridge or the freezer, or in a cold day outside, and kind of hear what they have to say to be able to, figure out if this is, true Raynaud's or just some skin changes that we'd expect to see in cold weather. As far as the renal involvement in lupus, it is very common, and about 50% of the patients with lupus end up having some sort of renal involvement with the lupus, and it is actually considered to be a significant cause of morbidity and mortality. And that's why I usually screen patients who have lupus and come to see me in clinic every few months for the presence of lupus nephritis. So initially I rolled this out as a possibility, and we are just basically just treating patients with extrarenal manifestations of lupus, whether they have the skin disease, mucocutaneous disease, they have pleuritis, they have arthritis. So we focus there. But every few months, I would say maybe every 3 to 6 months, I would just send some urine tests to screen them for any evidence of lupus nephritis that may have developed with time. So urinalysis to look for the protein, to look for blood, and then quantification of the proteinuria by checking a urine protein creatinine ratio. Of course, we routinely would check, a basic metabolic profile for those patients that would, get us the GFR to make sure that there is no change in their estimated GFR, to alarm what is going on here. Is the patient developing lupus nephritis that we're not aware of? So that is a very important part of our screening process for patients who have lupus and who are regularly followed and seen in clinic. And there are different forms of, lupus nephritis that can happen in those patients. And, the way we can tell exactly which form of glomerulonephritis those patients have or lupus nephritis would be by conducting a renal biopsy or so we can know which type and extent of involvement of the kidneys. And that also helps us guide the treatment for those patients. And the clinical presentation for patients with lupus nephritis is very variable. It can range from asymptomatic hematuria. It would have only detected if we've checked those urine tests, to full-blown nephrotic syndrome when patients can come and get admitted to the hospital with anasarca, or when we check some, basic metabolic profile as part of our, lab checks for patients who are routinely followed in clinic and notice that there is a significant increase in their creatinine and a drop in their GFR, and we're trying to figure out what is the cause for that. And so here in this table, I just wanted to again show you that the renal involvement in lupus and lupus nephritis can present in a wide variety of different manifestations. It can be as simple as very mild proteinuria or microscopic hematuria to having renal insufficiency, having a decline in the kidney function, hypertension. That's one thing that we commonly see in patients with lupus, complicated with lupus nephritis. So that's something to keep an eye on and make sure we adequately treat. So just to nephrotic range proteinuria, as I mentioned earlier, and we've had a few patients who ended up just diagnosed with lupus because they had this full-blown swelling all over, admitted to the hospital for anasarca, later on found to have lupus nephritis class 5. And here we mentioned the only way we can tell what kind of or what class of lupus nephritis we're dealing with is by getting a kidney biopsies on those patients. And we have 6 classes of lupus nephritis. It's important to note that with biopsy, our goal is to know whether the patient has class 3, class 4, or class 5. Simply because usually with class 1 and 2, the renal disease is considered to be mild. And usually those patients are still followed by nephrology, but they are not actively managing their immunosuppression, because at this point, they'll just be monitored for any change in their clinical picture as far as their lupus nephritis. So if they've had worsening proteinuria or worsening kidney function, then we will need maybe at some point to rebiopsy them just to figure out if they switch to a different class. Whereas if the patients ended up getting the kidney biopsy and we have either class 3, class 4, or class 5, those are the ones that we usually ask the help from nephrology to treat those patients along with rheumatology, and they will be, primarily managing the immunosuppression at the time. So it's important to note that class 5 is the one that usually present with nephrotic range proteinuria. So those are the patients who would just suddenly come into clinic and they have severe swelling, 3+ pitting edema in both their legs. So that's very characteristic of class 5. Class 4 tends to be also a very aggressive form of lupus nephritis that we worry about, especially if there is more than 50% involvement of the glomeruli. And usually we initiate patients as soon as possible on treatment, and that would include high dose steroids. That would include strong immunosuppression. Luckily, we have mycophenolate mofetil as an oral medication that works very well for a lot of those diseases, and that has decreased the use of cytotoxic other medicines like cyclophosphamide, which used to be the standard of care. We still use it sometimes, but we try to control the disease and manage the patients with medicines that causes the least side effects. And usually when it comes down to that, we are co-managing those patients between nephrology and rheumatology, they usually will monitor those patients, check, pretty frequently, check their urine tests and blood counts, and also, help us de-escalate immunosuppression whenever patients had been in remission. Usually we'll treat them for at least a couple of years. And if things are looking good, then at that point is when we start considering decreasing or de-escalating the immunosuppression while we're still monitoring the patients. Now, unfortunately, from biopsy, the patient ended up with class 6 of lupus nephritis, which is histologically will show glomerulosclerosis. when more than 90% of the glomeruli. At this point, unfortunately, patient has had much damage and fibrosis in their kidneys. At that point, nephrology may end up de-escalating immunosuppression, thinking that there is not much left in the kidneys to salvage. And so at that point, rheumatology will take over, immunosuppression to help treat extrarenal manifestations of lupus, whereas patients at that point may end up, needing an evaluation for either kidney transplant or initiation of dialysis based on how they're doing overall. So, this is a table that shows different classes of lupus nephritis and how important it is to know in which class the patient belongs, because this really affects the way we manage and treat those patients. And also talk about expectations of the treatments that we're giving to the patients. As far as the GI involvements in patients with lupus, they can occur in about 40% of patients. The majority of the GI symptoms that patients usually come back with are adverse events or side effects of the medications that we are using. And, sometimes it could be also viral or bacterial infections because also of the medicines that we're using. So either directly related to side effects of medications or treatments, which, we always talk about GI upset and, gastrointestinal side effects of medications that we use in lupus and in rheumatology in general, the first thing. And then the second thing we talk to the patients when we're counseling them about those medicines is that, those medicines also increase the risk of infection. So in general, it's important to note that those lupus-related GI abnormalities can involve any organ in the GI tract. The patients could have protein-losing enteropathy, they could have lupus hepatitis, pancreatitis, mesenteric vasculitis, or peritonitis. So a wide range of variety, and it's challenging because then we're trying to figure out, is this a side effect of the medicine? Is this an infection that we caused by giving the patients those medicines? Or is it, lupus trying to affect the GI tract? Pulmonary involvement in lupus can, develop at any stage throughout the disease. And again, pleuritis is very common, and it could happen with or without effusion. And typically patients will say, I've got chest pain, and usually it's a pleuritic in nature, where they're taking in deep breaths and cough. It could have pneumonitis, interstitial lung disease, pulmonary hypertension, shrinking lung syndrome, and alveolar hemorrhage. So alveolar hemorrhage, that's considered to be a life-threatening complication of lupus. And usually those patients will be admitted to the hospital and treated aggressively with immunosuppression and steroids. Shrinking lung syndrome, it is one of the pulmonary manifestations of lupus. Now, luckily, we don't see that a lot. It's not very common, but it is characterized by shortness of breath, pleuritic chest pain, progressive decrease in lung volumes on PFTs without evidence of ILD, interstitial lung disease, or pleuritic disease in the scan. So the scans will look fine, that the patient keeps coming with this shortness of breath and pleuritic chest pain, and then on PFTs they have this decreased volumes, decreased lung volumes. In most patients, the onset of this disease is usually within the first 4 years of diagnosis. And treating that, there's no specific treatment for this complication except that you're just treating the underlying disease, which is lupus. And then it's important to note again that respiratory symptoms must always be distinguished from infection, particularly in patients who are on immunosuppression. So when patients are coming with cough and shortness of breath, it's important to note, okay, let's make sure there's no infection going on causing those symptoms rather than the lupus acting up and be the reason for those symptoms. And also to think of the risk of thromboembolic, especially in lupus patients who have positive antiphospholipid antibodies. And neuropsychiatric involvement of lupus can also be a broad range of neurologic and psychiatric manifestations. So strokes, seizures, cognitive dysfunction, delirium, psychosis, and then less commonly peripheral neuropathies. It's not very common to see movement disorders or cranial neuropathies, meningitis, myelitis, but has been described in a few cases. And again, here thinking of thromboembolic events in association of antiphospholipid antibodies, as we thought about the cause for shortness of breath as far as pulmonary manifestations. Also thinking here of thromboembolic events in the setting of positive antiphospholipid antibodies, which can cause, strokes in some lupus patients. Arterial thromboemboli can cause some focal neurologic problems such as stroke or seizures or some diffuse cognitive deficits. And sometimes we have noticed, some of our lupus patients, even though they're young, you feel like it's really hard when they're coming to see us in clinic. It's really hard. We ask them, what medications are you taking? Or for example, if they say, if I've been having chest pain, trying to ask them, for how long have you had the chest pain? And sometimes they feel like, okay, well, I'm having memory problems. It's really hard for me to remember certain things. And it could be, part of, the disease affecting their neurologic system. As far as the hematologic abnormalities in lupus, that's a very important thing because, the CBC or the complete blood count that we get in lupus patients tells us a lot of whether this can be part of the lupus diagnosis or whether lupus is active or not. And anemia of chronic disease tends to be the most common type of anemia seen in lupus. Leukopenia is very commonly seen in lupus and happens in about 50% of patients and can present as either lymphopenia or neutropenia. And it generally correlates with disease activity. So we tend to check a CBC, every time the patient comes into clinic for two reasons. First, it can help us recognize if the counts are off and the patient is having cytopenia that he didn't have before. Is this a sign that the disease is flaring up? Or is it a complication of the medications that were given to immunosuppress those patients? And therefore, knowing that they have cytopenias related to that, then maybe we need to adjust the doses of those medications. Mild thrombocytopenia is commonly seen in lupus. Rarely we see severe thrombocytopenia that requires treatment. Autoimmune hemolytic anemia, we talk about it a lot in lupus, but it's very rare. And if it happens, it requires immediate and aggressive therapy. And lymphadenopathy in general can be seen in different parts and can be also a sign of active lupus, where we see lymph node enlargement in the cervical, axillary, and inguinal regions. As far as ophthalmologic manifestations of lupus, we depend on our ophthalmologists a lot to help.
I'm not sure if it's just my screen or if the connection has frozen. Is anybody else experiencing problems
with lupus? That could be because of secondary Sjogren's syndrome. The next most common pathologic condition that involves the eyes in patients with lupus is retinal vasculopathy. And we'll have a picture to show the form of cotton wool spots that can be seen in the retina. Other less common ophthalmologic manifestations would be optic neuropathy or episcleritis, scleritis, or anterior uveitis, so involving inflammation involving different parts of the eye. In addition, there are some specific ocular toxicities secondary to medications commonly used in lupus. And here we backtrack back to hydroxychloroquine. So hydroxychloroquine can cause some retinal toxicity. It's a very good medicine, but it comes without side effects. So usually we will screen patients about every year with dilated eye exams, send them to the ophthalmologist to make sure they haven't developed any side effects from being on the hydroxychloroquine for a long time. And I even do that before I initiate the hydroxychloroquine to also make sure that the patient doesn't have, a background retinal problems that will prevent me from using that safely. Also, our patients may end up being on steroids for some periods of time that can increase the risk for glaucomas, and therefore that would be another manifestation of eye disease seen in lupus, caused by medications used to treat the disease. And here, these are multiple pictures that go over. The first picture, shows the skin around the eyelids and the discoid lupus affecting the eyelids, and that can sometimes be really challenging and causing a great deal of discomfort for those patients. And the second picture shows, the dry eyes in lupus, which cannot be really distinguished from dry eyes caused by primary Sjogren's syndrome. And this is the corneal staining here in this picture with fluorescein showing a break in the tear film. The third picture shows scleritis, which is usually described as a painful red eye due to inflammation of the sclera. It occurs in about 1% of patients with lupus, can sometimes be the first sign of the disease and triggers the autoimmune workup to be sent by the ophthalmologist. The next picture showed the retinal vascular lesions that we talked about that commonly are seen in patients who have lupus. And then less commonly to see in the last picture some neuro-ophthalmologic involvement with cranial nerve palsies. Not very common, can be seen in some lupus patients, but I would say dry eyes being the most common. And usually, we treat those patients with prescription eye drops to help with their dryness in the eye. They are also co-followed by ophthalmology for further evaluation and treatments for that. And when they end up developing some sort of or any form of inflammatory eye diseases, when we work with the ophthalmologist to optimize their immunosuppression to keep it under control. So, this was kind of a more detailed review about different manifestations of lupus and how common they are. I wanted to talk a little bit about some associated conditions or some complications that we could see in patients with lupus. Antiphospholipid syndrome. We talked about antiphospholipid antibodies being detected in at least 40% of patients with lupus. However, the antiphospholipid syndrome, luckily, is much less common. So a lot of lupus patients may have the antibodies, but not necessarily the syndrome. And that, is very good not to have the syndrome, because, then they would require to be on anticoagulation indefinitely, and also they will be at risk of multiple embolic events. So it's important to remember that the antibodies are present, not necessarily the syndrome. The syndrome is less common, which is good. Fibromyalgia is a very commonly associated condition that a lot of lupus patients have. As well as, not necessarily just lupus patients, but a lot of patients who have other systemic rheumatic diseases. And it's important to note that there is a higher prevalence of fibromyalgia than the general population in patients with underlying rheumatic conditions. Osteonecrosis, which can present as severe joint pain in patients with lupus, varies. The risk of it varies widely from 3 to 40%, so a very wide range. But the increased risk is thought, of course, to be related to either the underlying disease or the prolonged use of steroids. Infection. Serious infectious complications, especially the skin, respiratory tract, or urinary system, can develop in about 50% of the patients. And usually those patients can present with some opportunistic infections that we're not used to see in the clinic or in the hospital. They could be some atypical fungal infections, and usually it is related to their underlying immunosuppressed status because of the immunosuppressive medications that were given those patients, and that can be a common cause of death, unfortunately. And it's always important to make sure that we have ruled out any possible reason for this patient to have a fever and ruled out any possible reason for this to be an infection before we blame it on their lupus and escalate their immunosuppression to help treat the fever. So any fever patient with lupus or on immunosuppressive therapy should first thing be ruled out to be caused by infection before we say, okay, this fever is really related to their underlying lupus acting up. And what are the risk factors for infection? In general, risk factors for infection in patients with lupus include long-term disease damage. So patients who've had lupus for years and years, and they've had so much damage from the disease. Patients who have chronic neutropenia or lymphopenia, so in general leukopenias. Hypocomplementemia or low C3, C4 complement levels, patients with renal involvement, and the use of glucocorticoids, of course, and higher doses of immunosuppressive therapy will increase the chances of those patients having infections. Moving on to go over some of the diagnostic criteria for lupus, and here I'm showing the ACR criteria for lupus, and then the SLE criteria, which was a little bit modified. And here with the ACR criteria, they said we have at least four of the 11 criteria to make the diagnosis. And then as far as the SLE criteria, which is a little bit more modified, they said we have at least 4 of the 13 SLE criteria, including at least 1 clinical criterion and 1 immunologic criterion. Or if the patient had a biopsy-proven lupus nephritis with positive ANA or double-stranded DNA. Now, I didn't want to spend so much time on these both criteria because I wanted to talk in more detail about the new criteria that came up in 2019, which is EULAR and the ACR criteria for systemic lupus diagnosis. And as a requirement for an entry criterion, patients must have a positive ANA with a titer of more than or equal to 1 to 80. So if it's absent, then patients cannot be classified to have lupus. And if present, then we can go ahead and apply additive criteria for that. And they had different criteria, and within these different criteria, we needed at least to have a score of 10 or more to if the entry criteria is fulfilled. And if we had more than one, if within each domain, we had more than one criterion, we will just choose the one that has the highest weight. So the different clinical domains and criteria they went over is constitutional symptoms if the patient has fever, hematologic, again, looking at the CBC to see if there's leukopenia, thrombocytopenia, or hemolysis. And here, for example, if the patient had leukopenia and autoimmune hemolysis, then we will choose just one that has the highest weight. So then it will be autoimmune hemolysis, and we'll give them the score of 4. Neuropsychiatric, there's delirium psychosis, mucocutaneous manifestations, oral ulcers, alopecia, pleural effusion or pericardial effusion. Joint involvement will get a score of 6, and then the renal involvement, whether it's different, whether it's a biopsy proven or proteinuria of more than 0.5 grams per 24 hours. And then as far as the immunologic domains, they wanted to, checking antiphospholipid antibodies can give a score. So that would be something to check on those patients if we are suspecting that they have lupus, because that can help us confirm their diagnosis throughout the criteria. The complement levels, C3 and C4, and then looking at the lupus-specific antibodies, which are the anti-double-stranded DNA and the anti-SMIF antibodies. So either or would give a score of 6. So that kind of new criteria is helpful in a way that, some patients, we will check an ANA on them. It comes out at 1 to 40. And that by itself, staying in that range at such a low titer will not even qualify to enter into this criterion to make the diagnosis of lupus. So this is kind of the most updated classification criteria of lupus. I hope this will be helpful and maybe help us, or help being a better guide for us to see if this patient would have lupus or not. And in each of those criterion, we have to make sure that there is no other explanation for any of those abnormalities besides lupus. Moving over to the evaluation and diagnosis of lupus, in general, what lab tests do we want to check on those patients? And, in general, as we mentioned earlier in previous slides, checking the blood counts is important because we want to know if there's any form of cytopenias that the patients have. A basic metabolic profile, mainly looking at the kidney number, the creatinine, making sure that patients don't have renal insufficiency. ESR CRP simply because that is part of the inflammatory workup, and we as rheumatologists, we like to check ESR and CRP. And also it reflects whether the patient has active disease. Urine test, as we mentioned, with urinalysis and urine protein creatinine ratio, it's part of the screening for any renal involvement in lupus. ANA, that would be checked whenever we have a clinical suspicion that patient's symptoms might be consistent with lupus and would clinically be significant if it's more than or equal to 1 to 80. And then more specific antibodies, the ENA, the extranuclear antibodies, and that include a variety of antibodies, the RMP, the SMIF, the SSA and SSB. RMP seen more commonly in patients with mixed connective tissue disease. SMIF is one of the specific lupus antibodies. And then the SSA, SSB, which are the Sjogren antibodies. And we do infection screening as part of initial workup when patients are seen in rheumatology clinic because we want to get them ready for immunosuppression if needed. And then, of course, imaging, we like to check their chest x-ray, look for any evidence of interstitial lung disease, pleural effusion, pericardial effusion, or any damage in their joints that would expect to see on their joint x-rays. And differential diagnosis, of course, we're talking about young patient population that is predominantly female, so definitely rheumatoid arthritis will be on top of the list when patients are presenting mainly with arthritis or inflammatory arthritis, especially that the distribution of the arthritis overlaps a lot with rheumatoid arthritis. Lupus is a diagnosis that I talked about in previous slides when we referred to an overlap between lupus and rheumatoid arthritis, when patients could have erosive arthritis, which is very atypical for lupus, but because they have an overlap between rheumatoid arthritis and lupus. Mixed connective tissue disease, usually they have, as I mentioned earlier, a positive RMP antibody, and they will have overlapping features of lupus, systemic sclerosis, and polymyositis. Adult onset cell disease, again, is on the differential. Usually those patients have negative ANA and they tend to have high ferritin levels. Fibromyalgia, as I said, it's very commonly seen in a lot of patients who have underlying rheumatic conditions and can cause, myalgias and arthralgia. So that's definitely there on the differentials. Infections like CMV and EBV infections, parvovirus B19, HIV, they can cause kind of similar constitutional symptoms, myalgias, arthralgia, so that would be on the differentials. And then specific malignancies like lymphomas and myelodysplastic syndrome, especially when patients present with diffuse lymphadenopathy with some abnormalities on their CBCs. I don't know if I was able to achieve what this slide says at this point, but I just hope that at this point we have a little bit better understanding, or feel like lupus is a little bit more clear than it was compared to the beginning of the talk. And this is a very important slide for me, simply because a lot of the referrals we get to dermatology is because of a positive ANA. And I wanted to note, and I always kind of go over this with my patients when they come to see me, that ANA can be seen in healthy patients or healthy general population, and just having a positive ANA by itself is not enough to diagnose lupus. And we've gone through that clearly throughout the presentation. And it's important to note that the percentage of the general population who have positive ANA, goes up the older they get. So the chances of having a positive ANA with higher titer in normal population actually goes up the older the patients are. So that's just one thing to keep an eye on and think of. Like 13% of positivity rate from the range of 180 to 160 titer can be seen in 12% of patients who are normal if they're in the age of 7 to 79 years old. So just note that the percentage of patients percentage of normal patients who could have positive ANA with higher titers increases with age. So it could be seen in patients who don't have lupus, even if their titers are higher than 1 to 80. And then this table goes over different conditions that can cause a positive ANA. So obviously the most common conditions here that we see at the top are rheumatic conditions. Lupus and drug-induced lupus being the most common causes for a positive ANA. Systemic sclerosis can also give a positive ANA, polymyositis, Sjogren's syndrome, rheumatoid arthritis. But lupus is on top of the list. But also it's important to know that there are some other non-rheumatologic conditions that can cause a positive ANA. And as we said, normal individuals, the more common in females, the older they are, or if they have relatives of rheumatic disease, if we screen those patients, they could have a positive ANA of unclear significance. Hepatic diseases, so patients with autoimmune hepatitis, patients with primary biliary cirrhosis, they can have a positive ANA. Pulmonary diseases, again, primary pulmonary hypertension, idiopathic pulmonary fibrosis can also give a positive ANA. Chronic infections and malignancies can give positive ANA. And that's why we're very careful when we are evaluating positive ANA in the setting of an acute infection, when this is sometimes sent while patient is being admitted to the hospital, or if the patient have active malignancies that they're being treated for, especially lymphoma, leukemias, and some solid tumors. ITP or hematologic disorders like ITP or autoimmune hemolytic anemia can cause a positive ANA, and some miscellaneous causes like type 1 diabetes, Graves' disease, multiple sclerosis. So in general, you feel like it can be seen in other autoimmune diseases that aren't necessarily rheumatic conditions. So that's something that I wanted to highlight. And briefly, I wanted to go over lupus in pregnancy. And again, we mentioned earlier, lupus predominantly affect women and women of childbearing age. And fertility in lupus does not appear to be affected by the disease itself. However, there's a decrease in the ovarian reserve in women who had been exposed to cyclophosphamide as a treatment option. Pregnancy in women with lupus carries a higher maternal and fetal risk compared with pregnancy in healthy women, of course. And the prognosis for both mother and child is best when the lupus has been quiescent or in remission for at least 6 months prior to pregnancy. So that is a conversation I routinely have with my patients who are, females in the childbearing age, especially if we bring up the topic of pregnancy, is that, well, it has to be planned. It has to be that the disease hasn't been active for at least 6 months, so we have best outcomes for mother and baby. Disease flares during pregnancy in lupus patients, and that's something that poses a challenge with respect to distinguishing physiologic changes that we expect to see in pregnancy or disease-related manifestations. And usually a multidisciplinary approach with close medical, obstetric, and neonatal monitoring is important to optimize both maternal and fetal outcomes. Usually pre-conception evaluation is very important, discussing the maternal and fetal complications and risk. We have to adjust the medications and may need to optimize disease activity. And we have to discontinue some medications. A lot of medicines we use in lupus are not compatible with pregnancy, and patients had to be off of them for a good time, at least a few months before they can get pregnant. We have to assess the disease activity, measure organ involvement, the hypercoagulability or concurrent medical conditions that the patients have that could impact the pregnancy. And it's important to note if they've had previous obstetric outcomes and that we review in particular attention to history of small for gestational age fetus, or if they've had history of preeclampsia, stillbirth, miscarriage, or preterm birth, because whatever has happened in the past, there's a higher chance that it could happen with the subsequent pregnancies. And going over lupus, lupus in pregnancy and what labs we would like to check, and that pretty much overlaps with all lupus patients. One thing I would pay extra attention to is usually if I haven't checked that, then I would check that on a patient who has lupus trying to get pregnant, is the SSA and SSB antibodies, simply because those antibodies can pass through the placenta to the baby and they can cause neonatal lupus or congenital heart blocks. So I'd like to know if the patient has them or not from the beginning, to notify the patients of risks of those antibodies and make sure that the high-risk OB doctor who is following that patient is aware of that so they can do the necessary screening for the fetus. Renal function that we do similar to what we do in general population that I've taught in general patients, in general lupus patients, like we mentioned before, the CBC, liver function test. And again, the double-stranded, anti-double-stranded DNA antibodies or complements are very important to check because they correlate with disease activity. APS antibodies or antiphospholipid antibodies, I also like to check those in patients who are trying to get pregnant if they haven't been checked before, because they can be associated sometimes with recurrent miscarriages. Hydroxychloroquine is recommended for all pregnant women to be used throughout the pregnancy, and it helps reduce the risk of lupus flares during pregnancy. Also, some data suggest a decrease in the occurrence of congenital heart blocks and at-risk fetuses of mothers with positive SSA or SSB antibodies. So that's another reason to use hydroxychloroquine during pregnancy. And low-dose aspirin is recommended in all women with lupus starting from about 12 weeks of gestation, as that helps reduce the risk of preeclampsia and restricted fetal growth, regardless of the presence of antiphospholipid antibodies. And I think this is even further recommended if patients have positive antiphospholipid antibodies, further supported. Medications that can selectively be used in pregnancy include, of course, NSAIDs. We try our best not to use anything, and if we can just maintain the patient on hydroxychloroquine, that will be great. But in certain occasions, patients have active symptoms that we will need to use a short NSAIDs, and we try to stick to the lowest dose and shortest duration of treatment between 20 and 30 weeks of gestation. Glucocorticoids, again, trying to stick with the lowest dose possible, and if we can, stick to less than 10 milligrams of prednisone. And azathioprine has been used. That is compatible with pregnancy. There is a little bit of risk, but we have to kind of make sure that the risk is acceptable to control the lupus manifestations during pregnancy, because leaving lupus flaring up throughout pregnancy without active treatment can pose risk for mother and baby. And in general, talking about drug-induced lupus, here I just wanted to highlight the high-risk medications associated with drug-induced lupus, procainamide and hydralazine, hydralazine is not commonly used for blood pressure control, but we've had a few patients on that, so something to keep in mind. Moderate risk is seen in patients who receive clonidine, and low risk in multiple medicines we use like carbamazepine, methyldopa, sulfasalazine, and minocycline. And the most common symptoms of drug-induced lupus are fever, joint pain, myalgia, rash, and sinusitis. We don't commonly see kidney disease or central nervous system disease in patients with drug-induced lupus. The lab testing, again, similar to what we would check in a patient who you're suspecting to have lupus. The highlight here is the antihistone antibodies that are commonly associated with drug-induced lupus and not necessarily with other forms of lupus. Hematologic abnormalities that are commonly seen in idiopathic lupus are not or commonly seen or rarely seen in patients with drug-induced lupus, with the exception of clonidine that sometimes can cause low complements. In general, low complements is not expected to be seen with drug-induced lupus. Diagnosis, reviewing history of, the medications that the patient has been taking. If there's one that, clicks there as one of the common medicines to cause drug-induced lupus, usually patients will have a positive ANA with the antihistone antibodies. Double-stranded DNA tends to be negative, and usually patients will have resolution of their manifestations within weeks after stopping the medication. Sometimes it may extend up to a few months. And it's important to note that the ANA can be persistently positive, sometimes for months or even years, even after the medication or the offending medication has been stopped. So, that is something to keep in mind. Treatment is usually by just discontinuing the medication that we thought is the trigger for the drug-induced lupus. Medical management may be needed in certain cases. There aren't any randomized trials that have examined the optimal treatment approach for drug-induced lupus, but usually management is based on observational data and experience of authors and other experts. So whatever we use to treat idiopathic lupus, we would probably use and be effective in patients who have drug-induced lupus. And generally, we will gradually keep those medicines and take them off as patients' symptoms are more controlled. And again, a quick review of medicines we use, NSAIDs if the disease is not too bad, short course of steroids if needed, and then hydroxychloroquine. And I mentioned multiple times throughout the slides, the association of antiphospholipid antibodies with lupus and antiphospholipid syndrome. The syndrome itself is characterized by venous or arterial thrombosis, or the presence of adverse pregnancy outcome in the presence of persistent lab evidence of antiphospholipid antibodies. In general, IPS can be primaries, it can be a disease on its own, or secondary, most commonly associated with lupus. Systemic lupus erythematosus is the disease is most commonly associated with APS of the rheumatic conditions, and it's present in about 35% of the cases. And usually we'll check the antiphospholipid antibodies at the beginning whenever we're seeing the patient, and if they're positive, we've got to confirm that those are continuing to be positive about 12 weeks later. And because of lack of time, I wasn't able to go into more detail through the lupus treatments, but in general, I wanted to make sure that we talk about hydroxychloroquine. As I said, it's a very important medicine for lupus treatment. It helps prevent lupus flares. It helps keep the disease under control. In general, it's a low risk medication. Patients require yearly eye exam to look for any retinopathy caused by the medication, and that would be a reason to stop it if it's there. Glucocorticoids are usually used at the initial diagnosis of the treatment since they work right away. And we're trying now with the new studies to stick with the lowest dose possible that will control the disease, so 0.5 milligrams per kilogram. Mycophenolate mofetil is one of the medicines that we use and works very well for lupus patients if they have lupus nephritis or if they have interstitial lung disease related to underlying lupus. One thing to note about it, it requires lab checks about every 2 to 3 months because it can cause cytopenias and those adjustments may be needed. Azathioprine also requires lab checks for the same reason about every 2 to 3 months. Belimumab is another medication that has been used for a few years now for extrarenal manifestations of lupus and had just gained the indication for lupus nephritis just recently. And new medications that were approved in 2021 are voclosporin for lupus nephritis and anifrolumab, which is an infusion that is used for extrarenal manifestations of lupus. So, at the end of my talk today, I wanted to make sure that we as clinicians in general recognize when to send the ANA and when it comes back, what it means, so we kind of give the patient an idea of what we are concerned about before referring them to rheumatology. The importance of use of systemic steroids when they are presenting to clinic with an acute lupus flare, which I'm sure is not common. You've seen that a lot of our lupus patients who come to the primary care physician because their lupus is acting up and they can't get in to see their rheumatologist because they are full for 3 to 4 months in advance. And so one thing the primary care physician can do is assess for disease activity, and if there's concern for active lupus, is maybe give them some steroids to control their flare up. Also checking C3, C4 levels in addition to double-stranded DNA as they correlate with disease activity, and that helps us recognize if the patient is having a flare up. Recognizing that lupus does flare up during pregnancy, and this will require us to see the patient more frequently, whether in a rheumatology clinic or maybe primary care clinic or the OB clinic, to make sure if the disease is acting up that we are treating it adequately. And consider the diagnosis of drug-induced lupus, and patients have been on a medication that commonly is associated with that. And also remember that their ANA can be persistently positive for a long time, even after the offending medicine has been stopped. Thank you, everyone. I hope this was a helpful lecture or talk, and I'll be happy to answer any questions or go over any comments from the audience.
There was a question in the chat. It was just asking what workup would you recommend a PCP to start before referral to rheumatology if SLE is suspected?
Right. So if clinically the patient is presenting with what it looks like is lupus, and the first thing is an ANA. And as we mentioned in the updated 2019 criteria, the ANA is mainly significant if it's more than or equal to 1 to 80. And if that is positive in that range, then I think checking a CBC with differential, as I mentioned, checking their basic metabolic profile to look at their creatinine, GFR, checking and screening their urinalysis and checking for protein or blood in the urine, that would be helpful to assess. And then it'll be helpful to have some of these sub-antibodies that we see in lupus, like Smith or double-stranded DNA, because that will have a good weight on that classification criteria. And then again, remembering complements, C3, C4 also can correlate to disease activity. So that and the double-stranded DNA. So if you have a patient with lupus diagnosing for the first time, definitely ANA, CBC, BMP, and some urine tests. And then if you feel like, okay, yeah, this is looking more like lupus, then you can go ahead and send more specific antibodies.
Thank you. Do we have any other questions or comments? Lots of comments thanking you, Dr. Kour, for a great talk.
Oh, well, thank you. Thank you, everyone.
I don't see any other questions right now, but I did put the link in the chat box if everyone can help provide their feedback. But if you have any additional questions, please feel free to reach out to me, and I'll be happy to pass those along. Thank you also for joining us, and thank you, Dr. Kour, for your presentation today.
Thank you very much. Have a great day.
You too.